Okay, folks, if all goes well, this will be our last lecture. Yeah, don't everybody cheer at once. Yeah, I built into the schedule a couple of extra days in case the big snow didn't happen on a holiday week, which timing was pretty nice. How many of you have to dig out when you got home? Yeah, a few. Very good. Well, thank goodness for shovels, right? Okay, so schedule-wise, we go through cardiovascular today, and then our final exam is next week on the 10th. Okay, that's Tuesday the 10th. So it's an off day, because we're usually Monday, Wednesday. And it's in this classroom from 3 to 5. You won't need 2 hours. It's going to be similar to what you guys have experienced. No surprises, okay? Probably 20-25% cumulative, and then the rest will be over the new material, okay? And I got your email, I haven't had a chance to respond. I got your email, I haven't had a chance to respond. I'm gonna schedule a couple of extra, I'll have office hours next week, normal schedule, but I'm gonna probably add maybe something on Friday, and maybe on Monday, I might actually extend the office hours a little bit, or add another time slot next week, okay? Just where I'll be in my office and available, okay? Sound good? I'll put those on BB Learn. All right. What's the best day to go to the beach? Sunday. I thought it would be appropriate considering it doesn't look like the beach outside. What bow can't be tied? A rainbow. Wow, you guys have learned a lot this semester. It's amazing. Unbelievable. Okay, how about this one? How many tickles does it take to make an octopus laugh? 10 tickles. Wow, you guys are like 3 for 3. Should we go 4 for 4? Let's do it. Okay. How does a dog stop a video? What hits the pause button? Man, you guys are so ready for the final. You know how proud I am right now? I mean, this is a very proud moment. 4 for 4. Incredible, incredible. So you guys have obviously learned a lot this semester. All right. On that note, let's finish up where we left off. Okay. Oh, I have to. All right, so this is post-Thanksgiving dinner. This is not a slice of turkey. All right, this was a atherosclerotic lesion. And we ended here where we were talking about how calcified and how hard this material was. So I'm just going to show you a couple of images of how we've analyzed these types of vessels in the lab. So imagine that cylinder is the blood vessel, and we take a piece of the top part and we use what's called nanoindentation. So I'm going to talk about nanoindentation. And then the unused piece at the bottom can be used for histology or something else. Okay? We take that specimen for nanoindentation, we longitudinally cut it, and then we open it up. So now instead of a cylinder, you actually have like a rectangle. And then from that rectangular piece, we can actually bring down the tip, and we can hit the surface with a certain amount of pressure, and it's going to exert an equal and opposite reaction force, and we can measure that. And from that, we can calculate hardness. And so this is the machine. This is a mechanical testing machine. This is a scanning electron micrograph of the very tip of that nanoindenture that's coming down. And so this Berkovich tip, you can see it's kind of like a pyramid. And that tip is what actually touches the surface of the vessel. And then we can actually generate hardness. And this is in pascals. Which is the measurement that we're using in this particular case. You can see basically on this scale a control vessel, artery number 2, has essentially zero hardness. It doesn't have any registration because of the scaling. And we've got two different disease vessels which are not statistically different from each other. And what I want you to be able to appreciate is the hardness value, while a 0.2 G Pascal doesn't make any sense to you, cortical bone probably does. All of you probably handled bone of some specimen, whether it's a soup bone or an anatomy lab, okay, or a steak bone, okay, or you're just weird and you collect bones. So cortical bone right here, you can appreciate that the hardness value of these vessels is approaching, now it's not the same value, it's statistically different, but it's approaching the hardness of cortical bone, which I thought was actually quite amazing. I didn't realize, when we talk about calcified vessels, bone is tremendously calcified. That's where you store a tremendous amount of your calcium, right? It's a calcium storehouse for you. And the osteoclast will break down the bone, release the calcium, the osteoblast will lay down bone and actually deposit calcium. So you can understand how we talk about stiffening or hardening, a sclerosis of the vessel, is literally these vessels are becoming bone-like. And the more diseased and the more calcified they become, the harder they become. And that's the whole point of these extra few slides, was just to drive home that point of hardness of these vessels. All right, let's talk about AS and what can happen. What are some of the results that can take place? Well, there's a preclinical phase, and in the preclinical phase, we've got development of the lesion. And that development is going to start from a normal vessel to what we call a fatty streak. And you get a little bit of fat that's starting to deposit, and then we've got a fibrofatty plaque that starts to mature. And then from there, it advances into a state where now it's considered a vulnerable plaque. And in the vulnerable plaque phase, we have significant vessel lumen narrowing. We know that this atherosclerotic, or this atheroma, is not just full of fat, but it's also full of calcified lesions, which is where we came from on that previous slide. And from this state, we can move into this clinical phase where we can have a number of different outcomes. We can actually compromise the integrity of the vessel wall, and you get an aneurysm or a rupture, and the vessel will bleed out. We can actually have the lumen itself be occluded by a thrombus. So that's just a blood clot that forms in that opening that's small. Or last, we can actually call this critical stenosis, where the vessel narrows down so much to the point where it blocks off all blood flow. Okay? So 3 potential outcomes of this vulnerable plaque. And all 3 of these clinical etiologies are causes of heart disease or ischemic heart disease. So if that's happening in a blood vessel that perfuses the myocardium, like one of the coronary circulation blood vessels, then we're going to be reducing blood flow to the heart in any one of these 3 circumstances. And then it's at risk of having what we call a myocardial infarction, or an MI, also known as a heart attack. So the different outcomes of atherosclerosis. So now I want to talk about a couple of different procedures and how we treat. So on this video, there shouldn't be any audio. I'm going to narrate anyways. So what you're seeing is that's an injection of contrast media, and that contrast media is showing that there's a blockage. So this contrast media, there's a blockage where it stops right here, and there's no distal perfusion of contrast media. So now the interventionalist is bringing this guide wire down. And you can see there's a tip of a guide wire way down here, and this contrast media is not perfusing this vessel. But you know that this is a vessel because here comes a wire, and right here, there's two markers, and they're inflating a balloon, and now they're going to re-inject, and they just reopened the vasculature. Did you see that? That was really fast, wasn't it? And it's moving around so. Why is it moving around so much and dancing so much? Because the heart's beating. You do this while the patient's heart is not arrested. So it's an active heart. And they reestablished distal blood flow. Do you see these two marker bands, these two dark regions? That's where the balloon is. And so what this physician has done is essentially reestablish distal blood flow by angioplasty or balloon angioplasty. So in this first image again, you can see that there's no distal blood flow right here. Where my arrow is, or my cursor, there's a lack of distal blood flow. Now they bring the balloon down and back, they position it, they inflate. You can see the balloon being inflated. Re-inject, and then reestablish blood flow. Now all of the subsequent images that you're seeing they're going back and they're touching it up. So they're going and they're repositioning the balloon, inflate a little bit more, bring it down, go to another little area that they think there was narrowing, inflate, bring it down. So this is balloon angioplasty and how it's used. It's literally that fast. So it's like painting a house, right? All of the prep work takes a lot of time in the OR or in the cath lab, but the actual case doesn't take that long. So they'll do a lot of prep work getting the patient ready, making sure that all the drugs are correct. In some cases, they might be under general anesthesia. In other cases, it might be local anesthetic. All right, now this one is narrated, so I'm going to let her do her thing in a second. This one is percutaneous coronary intervention where we've got a stent being placed. I wanted you to understand the difference between stent and balloon angioplasty. The stent is you inflate and you leave something behind to keep it open.
Percutaneous coronary intervention, also known as coronary angioplasty, opens narrowed coronary arteries. A small, hollow tube called a catheter is inserted into an artery in the groin or arm and threaded to the affected artery. A thin, flexible metal wire is then advanced through this tube and past the site of blockage in the artery. A second, smaller catheter is then inserted over the wire and threaded to the same artery. When it reaches the narrowed area, a small balloon on its tip is inflated to reopen the artery and flatten the blockage into the artery wall.
You see the stent being
while
expanded?
at the same time stretching the artery open to increase blood flow to the heart. Both catheters and the wire are then withdrawn. About 70 to 90% of coronary angioplasty includes placement of a stent, a wire mesh tube that holds open weakened arteries. The stent may prevent re-narrowing after an artery is widened, and it stays in place permanently as the blood vessel lining heals over it.
Make sense? So very similar to what we watched under fluoroscopy or under x-ray, slower, okay, in color, cartoon version, and then they leave a stent behind, okay? So balloon angioplasty versus balloon angioplasty with a leave behind stent. I'm going to say that today, and I haven't looked up these statistics, but that video's a little old. I bet it's closer to the 90% range where they leave a stent behind versus just doing balloon angioplasty. And now we actually have different types of stents. Now we actually have drug-eluting stents that we talked about before in the previous lecture. And those drug-eluting stents have, oh, seriously? There's going to be quite a few videos today. Okay, so these stents, that you can leave behind in the coronary circulation to treat atherosclerotic lesions can have usually an antiproliferative embedded or impregnated into that. Now, a lot of times that antiproliferative, what's it preventing the proliferation of? Those smooth muscle cells that like to migrate into that lesion. And those smooth muscle cells that migrate in, remember, they're non-contractile, and they replicate without stopping. And so that slowly narrows the lumen more and more. And so these antiproliferative coatings, like paclitaxel is one, is a broad-based antiproliferative that prevents these smooth muscle cells from actually doing that. Okay. Now, I want to talk about a different vessel. So we're in ischemic heart disease. Well, what happens if the vessel that's being narrowed with a lesion, or the vulnerable plaque as we've described, what if this vulnerable plaque with aneurysms is in a large vessel? Okay, and I spent a lot of my career in this space as well, and so I wanted to showcase to you one technology called the thoracic endograft. And its goal is to come in, now the thoracic aorta comes out of the left ventricle, right? Just distal to the aortic valve. And that large vessel is under pressure. And if there's high blood pressure, mean arterial pressure is elevated, and there's a lot of disease, then that can be a vulnerable plaque that's at risk of rupturing. Now, it could rupture, or it could create a defect in the thoracic aorta So here's our thoracic aorta, and then here's where the heart would be. Here's our aortic valve. And these defects typically happen in the neck of the aorta. And so this defect can be like this, which would be a saccular aneurysm. Okay? And this is obviously pressurized, and if this ruptures, you'll lose your entire blood volume into your chest cavity in about a minute. Right? If you're exercising, it'll be faster than that. Maybe 1 to 2 minutes. Okay? That's how quickly you'll lose your blood volume. Or this could be what we call a fusiform aneurysm that looks like this. Saccular aneurysms are more common. Fusiform aneurysms a little bit less common. But same underlying disease. It's this hardening of the vessel, but it's a large vessel. So I want to show you this video of treatments now that are being used. And this is a hometown company. This is Gore. I thought there was audio. Hang on. Maybe I paused the audio. Okay. So you're going to come in for more of a lateral view so you can actually appreciate the aorta. Spins a little bit. Here's more of a lateral view. And then do you see that fusiform aneurysm? Not necessarily saccular. So that's the guide wire that's going out, or in, I should say. Here's the catheter that's got the device crushed down on it. Here it is being deployed. And it basically just relines the thoracic aorta from the inside out. It's got a stent that has a fabric, so it's a covered stent. And they're ballooning the distal end first so it doesn't migrate. Then they'll cross the aneurysm. They'll come to the proximal landing zone. see from a cutout here. And they'll balloon, this is a special balloon we designed, a tri-lobe balloon that allows for blood flow while the balloon is inflated, so it doesn't occlude the vessel wall. It's got 3 separate lobes. You see that? Pretty cool. And that's how thoracic aneurysm is treated today. No drugs on these. It's funny, they restarted the heart, but the heart never stopped. It's just that one piece of editing that I thought was off, but that's okay. Then hearts, you never arrest the heart. Okay, questions? Questions on atheromas and how we treat, what's going on, why it's a problem? Okay, cool. Let's talk a little bit about ischemic heart disease, and then we'll describe angina. So ischemic heart disease, simply put, is there's an imbalance between demand and perfusion. So we're talking about the heart itself as a working muscle. And so the heart is going to have a requirement of blood flow in order to stay alive. And if you've got that underlying disease that we described, and you're narrowing these vessels, even if there's no aneurysm, there's just a stenosis that slowly closes over time. And let's pretend that the stenosis isn't 100%. That's fine. What if in the blood vessel, we've actually got a lesion, and we've got, say, 10% opening, right? So we've got 90% reduction. So it's not completely closed, but it's 90% reduced. Now, if the patient is just resting and not doing any activity, there may not be a lot of symptoms. But if they go to climb the stairs to go to the bathroom or go to the bedroom, then that's where they might experience problems, because the perfusion and the demand are out of balance. So the most common cause of ischemic heart disease is atherosclerosis, like we've been talking about. And if the blood flow isn't reaching the heart, then the heart's function as a pump is compromised. It's not able to eject as much blood volume on every heartbeat. Right? It's not even able to increase its heart rate to a significant level. Therefore, cardiac output is being compromised, according to that equation that we looked at last week. So, with ischemic heart disease, what do we see happening? Well, we've got the manifestations of angina pectoris. That literally means strangling feeling in the chest. We've got acute myocardial infarctions, or a heart attack that can happen. We've got chronic ischemic heart disease. So this can last long term. Maybe it's not 90% closed. Maybe it's only 70% closed, so it's 30% open. And that persists for 10 years. And now the heart has been compromised for 10 years. That would be a chronic ischemic heart disease situation. And in some patients, there's sudden cardiac death, where this narrowing happens either quick enough, or a thrombus or an embolus blocks this, and the patient has a terminal heart attack. And you hear of those happening as well. Not everybody survives their heart attacks. So angina pectoris translates to a strangling feeling in the chest. That's the actual literal meaning. And it's intermittent chest pain because of the myocardial ischemia. The heart is not getting enough blood flow. And so its response is to give you that feedback of pain in the chest. Now there's a couple of variations of angina. So stable angina is pain upon exertion. Like we talked about here, where the patient, maybe they're anywhere between 80 to 90% blocked, not full occlusion, and they're fine if they're watching television sitting on the couch, but the moment that they get up and start doing anything, they go walk the dog, they have chest pain. So that would be stable angina, that it's stable when they're at rest, but it's painful when they exert themselves. Congenital, or what we call variable. This is pain at rest, at night, and it's associated with significant vasospasms. Then unstable angina, or what we call crescendo, this is where it gets worse over a 3 to 4 day period. So maybe on Friday they had chest pain, and by Monday morning, over the weekend, it's actually consistent and worse than it was on Friday. So crescendo is a word that means to get louder. So question, what type of angina occurs because of vasospasms on one or more coronary arteries and often during sleep? Congenital, very good. Okay. So what are acute MIs? Acute myocardial infarctions. This is a word that we use to describe a heart attack. And what's taking place in the tissue is sort of a wave of ischemia. So just to orient ourselves, here's the aorta that we were describing a little bit earlier. Here's the heart. Here's our inferior and superior vena cava. We're going to be focusing on the left anterior descending artery. So the LAD, and right here is where you can see there's an acute coronary blockage. And downstream in this dotted area at the apex of the left ventricle is the zone that's at risk. That's the area that's being compromised because the blockage upstream is preventing blood flow from going downstream or distally. Over time, you're going to have an area that dies and becomes what we call infarcted. Now, these myocytes can last for about 20 minutes of ischemia before they die. So getting quick response by the ambulance to the emergency department and then getting the patient into the cath lab so they could come in here and open this up with a balloon or place a stent within 20 minutes is absolutely really important. Doesn't always happen. If it doesn't happen, then this area becomes scarred and it never recovers. If you can hit it under the 20 minutes, then oftentimes you can actually save this tissue and the patient's going to be relatively okay. Now, the bottom panel of images is talking about this wave of ischemia. Because of the way that the blood flow perfuses the tissue, the endocardium is the area that dies first. Because the coronary vessels are on the epicardial surface, and they dive deep into the myocardium and then to the endocardium. So the last area that gets blood is the endocardium. So it's the first area within the first 2 hours that actually dies off. And then in a 24-hour period, you go from a endocardial or subendocardial infarct to what we call a transmural infarct. So a transmural infarct, after a 24-hour period, is all the way through the myocardium. Endocardium all the way to epicardium. Does that make sense? So I don't have the histology here, but if I showed you histology of a transmural infarct, you should be able to see that the wall is narrow, right? And it's full of a lot of scar. That would make sense because that would be the fibrosis that we've been talking about all semester. Does that make sense? Okay, so I don't have histology, but I have gross images. So let's look at this. So if a patient has a heart attack and they present to the emergency department and they get to the cath lab, we're going to draw blood. And we're going to look in the blood for certain types of lab findings or assays to give us an indication of how great of an extent was the infarct, or was there an infarct. So let's talk about that. Well, this picture up top is showing you glycolysis. And I'm not going to ask you to memorize glycolysis for the exam for the final next week, but this is just to refresh your memory that the heart is an aerobic organ. It likes to generate energy using aerobic respiration. So if blood flow is compromised, what is it going to do? It's going to go anaerobic. It's going to do everything it can to keep up with an energy utilization, even though there's not oxygen. Why is there not oxygen? Because there's no blood flow. Make sense? So this conversion to glycolytic pathways is its effort to try to save itself. It's temporary, and it's not going to last forever. And you can imagine if you're heavy into glycolytic pathways, what type of lactic acid levels will you detect? Or pathways of anaerobic fermentation, right? Byproducts, they're going to go up. So you can imagine that lactic dehydrogenase is going to go up, right? That's the last one on the list. You can imagine that CKMB, this is creatine kinase myocardial bound, this is going to go up, and CKMB rises within the first 2 to 4 hours, and it peaks 24 to 48 hours post-infarct. But you really have to measure it before 72 hours on a patient because it starts to decline. Troponin I and troponin T, well, these are part of the cross-bridge formation architecture. And so what ends up happening is they're not strongly attached. So if you have an infarct and you're going to have myocardial trauma due to a blockage, you're going to lose these TNI and TNTs very early on. And so they start floating around the bloodstream because they came out of the myocardial tissue because you had trauma due to an infarct, okay? So it's TNI and TNT, they also appear within 2 to 4 hours in the blood post-infarct. They peak at 48 hours, and they remain elevated for a week to 10 days, 7 to 10 days. And then the last thing on the slide that I want to point out is, I want to point out the architecture. Let me dim this. I got it right that time. So this is left ventricle, right ventricle, okay? And if you take a look at this tissue right here, this is all infarcted right ventricle. Here is a higher magnification view. So all of this whitish colored tissue is all infarcted on the endocardial front. Now, if this was a transmural infarct, you would imagine that this scar would actually migrate all the way through, and you would have sort of this purplish stained tissue, right? So this is a heart that's been stained. This purple tissue is all viable tissue, and then this sort of whitish colored tissue is all of the infarct. So if it was a transmural infarct, you wouldn't see the purple viable tissue. It would actually be white all the way through. Make sense? So this is the left ventricle on your right side. The right ventricle of this patient, this is a subendocardial infarct on the right side. And usually we're talking about over here, but this particular picture is showing the right ventricle. Okay, what kind of complications can come up from a patient with an MI? Well, obviously death isn't on the list, but you could write it down. I mean, if they don't survive the infarct, which does happen, then death would be a result. Arrhythmias, because it can do damage to the electrical system. There can be contractile dysfunction as a result of the damage to the electrical system. Myocardial aneurysm or a rupture. What we call a mural thrombus, and this is a picture of a mural thrombus, and that black arrow is pointing to basically a tear in the wall of the ventricle. due to this old myocardial infarction where that tissue is weakened, and so over time it tears, it wears out. And then progressive heart failure. So if a patient has, let's say in their 60s, they have a myocardial infarct and they survive, and the heart remodels, they're at high risk of developing heart failure in the next 10 years. Make sense? The heart was weakened, the patient lives on. If the patient becomes hypertensive and they have a weakened heart, then it moves into a heart failure situation. Okay, a couple of additional categories to cover for today. But these will go pretty quickly, and we should finish a little early. So valvular diseases. So we've got 4 valves that we talked about or we introduced last week, right? On the right side of the heart, we have our tricuspid valve. That separates the right atrium from the right ventricle. And then we have the pulmonary valve, which controls blood flow out of the right side of the heart, or the right ventricle, to the lungs. We've got our mitral valve that separates our left atrium from our left ventricle. And then we have our aortic valve, which is the interface between the left ventricle and the aorta. And these two on the right side of the slide, but the left side of the heart, so the aortic valve and the mitral valve, otherwise known as the bicuspid valve, these are the two that are most at risk of developing disease. Why is that? We mentioned it, but let's repeat or refresh. Higher pressures. Higher pressures on the left side than on the right side. Now we get 2 main categories of valve replacements. We have mechanical valve replacements. This is a bileaflet valve replacement. And then we have biological. And the biological are typically porcine or pig, or bovine or cow. And they take them out of these organisms, and they process them, they clean them, they sterilize them, okay? And they fix them. They fix them in a fixative that cross-links the protein so these don't deteriorate. And we've been doing this for decades. But these are the 2 main categories. They're either mechanical or prosthetic, or we have biologic. There are newer and newer methods now, because to replace a valve is typically an open chest procedure. But now there are, on the left side of the heart, there are aortic and even mitral valve replacements being done using catheter-based technologies. It's like some of the videos I showed you where they're fishing a wire all the way through, and then they're deploying catheters. Now they're replacing valves doing that. Okay. It's not mainstream, it's in clinical trials, but that's where the field has gone. So signs and symptoms of valve disease. Abnormal sounds, or what we call murmurs. So they call them heart murmurs, but it's actually the valve that's not functioning correctly. Patient feels fatigued, they have shortness of breath, swelling of the ankles and the feet because you've got a backup of fluid, dizziness, fainting, and an irregular heartbeat. Pretty self-explanatory what we would expect. Pericarditis. Pericarditis is a disease of the pericardial tissue, and it's inflammation of that tissue. And the causes could be a number of different things. Viral infections are the most common cause. Pericarditis also often follows respiratory infections in older patients. It could be inflammation that happens following surgery, like to repair a myocardial infarction. This particular picture is showing you where we are. So we've got the pericardial tissue, which is the sac that wraps the heart. And we really have 2 layers. We've got our parietal, which is the outer layer, and then we have our visceral pericardium, which is essentially synonymous with the epicardial surface. So the visceral pericardium and the parietal pericardium, in between them is a little bit of fluid. and it's a lubricious fluid. And so when the heart beats in this sac, it actually doesn't cause friction against that surface. But you can imagine if something was to get into that area, like a virus, it would be very easy for it to irritate the pericardial surfaces, whether it's the parietal or the visceral surface. Some other causes, autoimmune disorders that we looked at before, like rheumatoid arthritis or lupus. In some circumstances, cancer can metastasize into this space, particularly with lung cancer or breast cancer or in leukemia. What do patients experience and how do we treat? Well, most of the treatment is anti-inflammatories to try to quench that inflammation that's causing that irritation. So usually there's a sharp stabbing chest pain, different than angina, which is more of a strangling type of pain, or more of a dull pain. Shortness of breath, heart palpitations, low-grade fever. Low-grade fever because the patient is actually starting to go more systemically into shock with this infection. So the way to treat this, non-steroidal anti-inflammatory agents to lower the inflammation, steroid treatments, and antibiotics if there's an infection. Rarely do we do surgery, and one of the reasons for that is, what would you really do? There's not much you can do to repair inflammation on a tissue, other than to take the tissue out, and that's not really an option here. Okay, our last category, which is a tough one to talk about, but the good news is, and I got another video, is there's some really great new therapies that are coming onto the market. But these are congenital heart diseases. Okay, so in this lecture series, we've covered 6 different disease states. And the last 3 we've gone pretty quickly over, but they're less common than like heart failure. They're less common than heart disease. They're less common than atherosclerosis. But for sake of completeness, I wanted to make sure that we covered all 6 categories. But this last one is a little tough because these are congenital defects and they involve little kids. Many of these defects, or these congenital defects of the heart, fall into the category where there's a atrial septal defect. Not all of them, but that's the biggest category. So some kids are born where the heart is actually backwards, or where the heart is actually either upside down or sideways in the chest cavity. Very, very rare. Okay, but most common congenital heart defect is there's actually a perforation between the left and the right side of the heart, what we call an atrial septal defect, or an ASD. Called a hole in the heart, and you can see from this cartoon drawing, this one's actually showing it at the level of the ventricle system. There are ones that have to go up a little bit higher that are going to be characterized on this particular slide. So we've got, here's a ventricular septal defect that's happening up top here. Here's one that's ventricular septal defect that's down a little bit lower. So there's normal heart circulation here, and then hearts with these septal defects that are shown on the right side of the slide. Now, one in particular that is fairly common is called a PFO, right? So this is a patent foramen ovule. So in development, there's actually a normal opening between the right and the left atrium. And after birth, as soon as the baby takes its first breath, the pressures in the thoracic cavity change. And it puts new pressures into the lungs, and that causes a backwards pressure on the right side of the heart. And then there's a flap of tissue that actually closes off this opening. And then it heals over, and in all of us, our foramen ovule was closed at birth, and you can't really see it anymore. Excuse me. But in some patients, that flap of tissue never closes over. And so you can imagine from a fluid mechanics of what we talked about, from that blood flow, you've got mixing of deoxygenated and oxygenated blood. You've got less pressures moving from the left atrium to the left ventricle. And therefore, you've got less efficiency on every ejection fraction coming out of the left side of the heart. So, what are ways that we can treat these today? So let me show you. This is a really cool tech. I didn't work on this one. This one's really cool. Again, hometown hero. This is called Cardioform. Sure, whatever. So there's a wire, not an open chest procedure by the way. Wire goes through, catheter goes through. Deploy one side of the device, open it up, close. You saw that tissue flap. Did you see that tissue flap that wasn't quite fully formed? Pull it through, close the other side, and then release a little bit of an anchor. And then head to the golf course. Pretty cool, huh? And then watch over time, and the artist kind of shows how it heals. And you got new tissue healing over top of it, and it closes off that opening. And that's being done today. And there's a couple of other devices on the market, but I kind of picked the local guys. Questions? Yeah.
Is that a permanent device then?
Yeah, that's a permanent device. The thoracic endograft, as well as the PFO device, those are leave-behind devices. You're not going to go back in and take them out. That's actually one of the topics of question among some of these technologies, especially when you treat younger patients. So for example, take the thoracic aorta. Less obvious, but in the thoracic aorta, your aorta dilates as you get bigger. So if you got treated in your 30s, well, let's say you got treated in your 20s because you had a transection. We talked about the motorcycle accidents. You had a transection. Well, that device that's in there, that's probably a 20, 21 millimeter diameter device for 2.1 centimeters. By the time you're in your 60s, your aorta might be twice that size, might be 40 millimeters. So now what you have is you've got a aorta that has essentially what we call a coarctation. And this is where the old device is. So that's called a coarctation, and that actually presents new challenges. Right? And then the same thing for the PFO. These are infants. And so what happens is that, but the heart's going to grow, and then the PFO would stay in the same location. And in you and I, it doesn't change at all because it's been fibrosed over. And so I think there's less concerns in these pediatric cases down the road because the heart's going to enlarge around it, and it's not like there's going to be any change of that particular location anyways. Yeah, but that's a really good question.
Do they use different devices for like a ventricular septal defect because like higher pressure?
Yes, they do. Yeah.
Do they look different than that?
They're very similar where it's kind of like a dumbbell concept where you come in, you deploy this side, and you back up and deploy this side, and then smash it together.
Yeah.
Yeah. So very similar types of designs and concepts, and you can imagine from a patent standpoint, there's all sorts of patent protection everywhere. Yeah.
This one's kind of random, but like, what does like a pacemaker do?
Oh, that's a good question. So pacemakers. So there's pacemakers and defibrillators. And pacemakers literally keep the rhythm of the heart. So your SA node on the right side of the heart fires on its own and it keeps the rhythm. And so sometimes if you have an infarct or damage to the heart, that electrical connection is compromised. So a pacemaker will come in and it'll set the heart rate for the patient. And those are outpatient procedures. They implant the wires, and then usually subcutaneously is where they'll tuck the little brain, if you will. And it usually, goes somewhere in the chest area, but underneath the skin. And then the wires are fished to the actual myocardium itself. And then a defibrillator is like a pacemaker plus. So a defibrillator, what that does is, if the heart starts acting weird and putting electrical signals in inappropriate timings, it actually acts like those defibrillation paddles that or a defibrillator that might be hanging in a public, like a concert hall or at the stadium or something like that. And so it delivers a shock to the heart to reset it, so that you're not sitting there. A lot of times when a heart needs to be defibrillated, is the right and the left ventricle are pumping at the same time. And so that, you can imagine like squeezing a tube of toothpaste. How many of you squeeze the tube of toothpaste according to the instructions? From this end, and then you move towards the nozzle, right? How many of you?
Depends on how much toothpaste you got left.
So it depends on, well, then you go over the edge of the counter and you can, right? How many of you squeeze that way? Come on, be proud. How many of you just grab it and squeeze? And whether the cap goes on, sometimes the cap can go back on because it's so goopy, right? So you're like, forget the cap, right? Okay. So if you can imagine a tube full of fluid and you want to be efficient, then you'll squeeze here, then here, then here, then here, then here. So the heart is basically a tube. It's just a tube in a U. And so if this side squeezes, it propels fluid to this side, and then this side squeezes and propels fluid out. If they both squeeze at the same time, then the blood doesn't move, and then it needs to be defibrillated. Does that make sense? Good questions. Anything else? All right, that wraps up our semester. We'll take Wednesday as a study day. I'll post some additional office hours. I'll have office hours on Monday. I'll probably have extra office hours on Monday. I might have another office hour like on Friday of this week. Okay? Thanks, you guys.